Foundations of Maternal Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 19. Normal Newborn. Process of Adaptation. At birth, neonates must make profound physiologic changes to adapt to extrauterine life and meet their own respiratory, digestive, and regulatory needs. This chapter focuses on these changes and will assist nurses in identification of behaviors that signify problems or abnormalities. It provides a foundation for discussion of nursing assessment and care related to those changes detailed in chapters 20 and 21. Initiation of respirations. The first vital task the newborn must accomplish is the initiation of respiration. Forces occurring throughout pregnancy and during birth bring about this change. Development of the lungs. During fetal life, the alveoli produce fetal lung fluid that expands the alveoli and is essential for normal development of the lungs. Some of the fluid empties from the lungs into the amniotic fluid. The lung fluid is continuously produced at a rate of 4 to 5 milliliters per kilogram per hour. As the fetus nears term, the amount of fetal lung fluid produced decreases in preparation for birth, when the fluid must be cleared for the infant to breathe air. Absorption of lung fluid begins during early labor, and by the time of birth, approximately 35% of the original amount remains. During labor, the fluid begins to move into the interstitial spaces where it is absorbed. Absorption is accelerated by secretion of fetal epinephrine and corticosteroids, but may be delayed by cesarean birth without labor. The removal of the fluid helps reduce pulmonary resistance to blood flow that is present before birth and enhances the advent of air breathing. Surfactant, a slippery detergent-like combination of lipoproteins, is detectable by 24 to 25 weeks of gestation. Surfactant lines the inside of the alveoli and reduces surface tension within alveoli, allowing the alveoli to remain partially open when the infant begins to breathe at birth. Without surfactant, the alveoli collapse as the infant exhales. The alveoli must be re-expanded with each breath, greatly increasing the work of breathing and possibly resulting in atelectasis. By 34 to 36 weeks of gestation, sufficient surfactant is usually produced to prevent respiratory distress syndrome. Surfactant secretion increases during labor and immediately after birth to enhance the transition from fetal to neonatal life. Steroids given to a woman in preterm labor help increase surfactant production and speed maturation of the lungs. The fetus with intrauterine growth restriction or stressed by conditions such as maternal hypertension, heroin addiction, preeclampsia, infection, placental insufficiency, or premature rupture of membranes greater than 48 hours also may have accelerated lung maturation. Infants of mothers with diabetes have slower lung maturation. Causes of respirations. At birth, the infant's first breath must force the remaining fetal lung fluid out of the alveoli and into the interstitial spaces around the alveoli to allow air to enter the lungs. This requires a much larger negative pressure, suction, than subsequent breathing. Breathing is initiated by chemical, mechanical, thermal, and sensory factors that stimulate the respiratory center in the medulla and trigger respirations. Chemical factors. Chemoreceptors in the carotid arteries and the aorta respond to changes in blood chemistry caused by the hypoxemia that occurs with normal birth. A decrease in the partial pressure of oxygen, PO2, and pH, and an increase in the partial pressure of carbon dioxide, PCO2, in the blood cause impulses from these receptors to stimulate the respiratory center in the medulla. However, stimulation of the respiratory center and breathing do not occur if prolonged hypoxia causes central nervous system depression. Mechanical factors. During a vaginal birth, the fetal chest is compressed by the narrow birth canal. Approximately 1/3 of the fetal lung fluid is forced out of the lungs into the upper air passages during birth. The fluid passes out of the mouth or nose as the head emerges from the vagina. When the pressure against the chest is released at birth, recoil of the chest draws a small amount of air into the lungs and helps remove some of the viscous fluid in the airways. This reduces the amount of negative pressure needed for the first breath after birth. Thermal factors. The temperature change that occurs with birth also stimulates the initiation of respirations. At birth, the infant moves from the warm, fluid-filled uterus into an environment where the temperature may be much cooler. Sensors in the skin respond to this sudden change in temperature by sending impulses to the medulla that stimulate the respiratory center and breathing. Sensory factors. Tactile, visual, and auditory and olfactory stimuli occur during and after birth to stimulate sensors. Nurses hold, dry, and place infants skin to skin with the mother or wrap them in blankets, providing further stimulation to skin sensors. The stimulation of the light, sound, smell, and pain at delivery also may aid in initiating respirations. Continuation of respirations. As the alveoli expand, surfactant allows them to remain partially open between respirations. Approximately 20 to 30 milliliters of air from the first breaths remain in the lungs to become the functional residual capacity, FRC. Within the first hour after birth, 80 to 90% of the FRC is established because the alveoli remain partially expanded with this residual air. Subsequent breaths require much less effort than the first one. As the infant cries, pressure within the lungs increases, causing remaining fetal lung fluid to move into the interstitial spaces, where it is absorbed by the pulmonary, circulatory, and lymphatic systems. Complete absorption may take several hours. This explains why the lungs may sound moist when first auscultated, but become clear a short time later. Cardiovascular adaptation. Transition from fetal to neonatal circulation. During fetal life, three shunts, the ductus venosus, foramen ovale, and ductus arteriosus, carry much of the blood away from the lungs and some blood away from the liver. High pressures within the collapsed fluid-filled lungs permit only a small amount of blood flow into the narrow pulmonary vessels. At birth, the shunts close and the pulmonary vessels dilate. These changes occur in response to increases in blood oxygen and shifts in pressure within the heart, pulmonary, and systemic circulations, as well as clamping of the umbilical cord. The alterations necessary for transition from fetal to neonatal circulation occur simultaneously within the first few minutes after birth. They are discussed separately here. As the newborn takes the first breaths at birth, the rise in oxygen concentration causes the ductus arteriosus to constrict, preventing entry of blood from the pulmonary artery. At birth, pressures between the right and left sides of the heart are reversed. The sudden dilation of the vessels of the lungs allow blood to enter freely from the right ventricle and decreases pressure in the right side of the heart. Clamping of the umbilical cord closes the ductus venosus and further decreases pressure in the right side of the heart. Increased blood flow from the pulmonary veins into the left atrium causes pressure in the left side of the heart to build. Systemic resistance increases as blood flow to the placenta ends with clamping of the cord, and this also elevates pressure in the left heart. The foramen ovale's flap valve closes when the pressure in the left atrium is higher than that in the right atrium. This change forces the blood from the right atrium into the right ventricle and pulmonary artery. Because the ductus arteriosus is also closing, the blood continues into the lungs for oxygenation and returns to the left atrium through the pulmonary veins. Blood from the left atrium enters the left ventricle and leaves through the aorta to circulate to the rest of the body. Thus, blood flow through the heart and lungs changes from fetal to neonatal circulation and is similar to that in the normal adult. Conditions such as asphyxia, insufficient oxygen and excess carbon dioxide in the blood and tissues, and persistent pulmonary hypertension may reverse the pressures in the heart and cause the foramen ovale to reopen. The ductus arteriosus closes gradually as oxygenation improves and prostaglandins, which helped keep it open, are metabolized. Until closure is complete, a small amount of blood may shunt through the ductus arteriosus from the aorta to the pulmonary artery. This sequence occurs because pressure in the aorta has become higher than that in the pulmonary artery. A murmur may be heard as a result of blood flow through the partially open vessel. Low levels of oxygen in the blood may cause the ductus arteriosus to dilate and the pulmonary vessels to constrict, increasing resistance to blood flow to the lungs. The result may be opening of the foramen ovale to allow a right to left shunt of blood and flow from the pulmonary artery through the ductus arteriosus and into the aorta. A patent ductus arteriosus may occur in the infant who experiences asphyxia at birth, becomes hypoxic, or is preterm. Neurologic adaptation, thermoregulation. At birth, the infant must assume thermoregulation, the maintenance of body temperature. Although the fetus produces heat in utero, the consistently warm temperature of the amniotic fluid and the mother's body make thermoregulation unnecessary. The infant's temperature may drop as much as 0.2 to 1 degree Celsius, 0.5 to 1.7 degree Fahrenheit, per minute if the infant is not kept warm at birth. Neonates must produce and maintain enough heat to prevent cold stress, which can have serious and even fatal effects. Newborn characteristics that lead to heat loss. Certain characteristics predispose newborns to lose heat. The skin is thin, and blood vessels are close to the surface. Little subcutaneous or white fat is present to provide a barrier to heat loss. Heat is readily transferred from the warmer internal areas of the body to the cooler skin surfaces and then to the surrounding air. Newborns have 3 times more surface area to body mass than adults, which provides more area for heat loss. Newborns lose heat at a rate 4 times greater than that of adults. The healthy full-term infant remains in a position of flexion, reducing the amount of skin surface exposed to the surrounding temperatures and decreasing heat loss. Sick or preterm infants have decreased muscle tone and are unable to maintain a flexed position. Preterm infants also have thinner skin and even less white subcutaneous fat than full-term infants. Therefore, they are at increased risk for cold stress. Methods of heat loss. Heat is lost in 4 ways: evaporation, conduction, convection, and radiation. The nurse can prevent heat loss by each method and must be watchful for situations in which intervention is needed. Evaporation. Evaporation is air drying of the skin that results in cooling. Drying the infant, especially the head, as quickly as possible helps prevent loss of heat by evaporation. Insensible water loss from the skin and respiratory tract increases heat loss from evaporation. Conduction. Movement of heat away from the body occurs when newborns have direct contact with objects that are cooler than their skin. Placing infants on cold surfaces or touching them with cool objects causes this type of heat loss. The reverse is also true. Contact with warm objects increases body heat by conduction. Warming objects that will touch the infant or placing the unclothed infant against the mother's skin, skin to skin, helps prevent conductive heat loss. Convection. Transfer of heat from the infant to cooler surrounding air occurs in convection. When infants are in incubators, the circulating warm air helps keep them warm by convection. Providing a warm, draft-free environment avoids convective heat loss. Radiation. Radiation is the transfer of heat to cooler objects that are not in direct contact with the infant. Infants in incubators transfer heat to the walls of the incubator. If the walls of the incubator are cold, the infant is cooled, even when the temperature of the air inside the incubator is warm. To combat this problem, incubators have double walls. Placing cribs and incubators away from windows and outside walls minimizes radiant heat loss. Newborns can gain heat by radiation too. Using a radiant warmer transfers heat from the warmer to the cooler infant. Non-shivering thermogenesis. When adults are cold, they shiver, increasing muscle activity to produce heat. Shivering is not an important method of thermogenesis for newborns, who rarely shiver except during prolonged exposure to low temperatures. Instead, they become restless and cry. Their increased activity and flexion help generate some warmth and reduce the loss of heat from exposed surface areas of the body. Exposure to cool temperatures also results in peripheral vasoconstriction, decreasing flow of warm blood to the skin. This helps prevent heat loss from the skin and causes the skin to feel cool to the touch. In addition, a drop in temperature increases the metabolic rate as much as 200 to 300%, causing above normal oxygen and glucose use. The primary method of heat production in infants is non-shivering thermogenesis, NST, the metabolism of brown fat to produce heat. Newborns can increase heat production by 100% using NST. Brown fat, also called brown adipose tissue, BAT, contains an abundant supply of blood vessels that causes the brown color. Brown fat is located primarily around the back of the neck, in the axillae, around the heart, kidneys, and adrenals, between the scapulae, and along the abdominal aorta. As brown fat is metabolized, it generates more heat than white subcutaneous fat. Blood passing through brown fat is warmed and carries heat to the rest of the body. NST begins when thermoreceptors in the skin detect a skin temperature of 35 to 36 degrees Celsius, 95 to 96.8 degrees Fahrenheit. Thermoreceptor stimulation is transmitted to the hypothalamic thermal center. As a result, norepinephrine is released in brown fat, initiating its metabolism. NST goes into effect even before a change occurs in core interior body temperature, as measured with a rectal thermometer. Activating thermogenesis before core temperature decreases allows the body to maintain internal heat at an even level. Therefore, NST may begin in an infant when skin temperature has been cooled, even though core measurements show normal readings. A decreased core temperature will not occur until NST is no longer effective. Some infants have inadequate brown fat stores. It is accumulated mainly during the third trimester, so preterm infants may be born before adequate stores of brown fat have accumulated. Intrauterine growth restriction may deplete brown fat stores before birth. Hypoxia, hypoglycemia, and acidosis may interfere with the infant's ability to use brown fat to generate heat. These infants are not able to raise their body temperature if they are subjected to cold stress and may have serious complications. Hazards of cold stress: increased oxygen need, decreased surfactant production, respiratory distress, hypoglycemia, metabolic acidosis, jaundice. Effects of cold stress. Cold stress causes many body changes. The increased metabolic rate and metabolism of brown fat that result from cold stress can cause a significant rise in need for oxygen. If an infant is having even mild respiratory distress, the problem may be exacerbated if added oxygen is used for heat production. Cold stress also causes a diminished production of surfactant, impeding lung expansion and leading to more respiratory distress. Glucose is also necessary in larger amounts when the metabolic rate rises to produce heat. When glycogen stores are converted to glucose, they may be quickly depleted, causing hypoglycemia. Continued use of glucose for temperature maintenance leaves less available for growth. Metabolism of glucose in the presence of insufficient oxygen causes increased production of acids. Metabolism of brown fat also releases fatty acids. The result can be metabolic acidosis, which can be a life-threatening condition. Elevated fatty acids in the blood can interfere with transport of bilirubin to the liver, increasing the risk for jaundice, yellow discoloration of the skin, and sclera caused by excessive bilirubin in the blood. As the infant's body attempts to conserve heat, vasoconstriction of the peripheral blood vessels occurs to reduce heat loss from the skin surface. Decreased oxygen concentration in the blood, however, also may cause vasoconstriction of the pulmonary vessels, leading to further respiratory distress. Neutral thermal environment. A neutral thermal environment is one in which the infant can maintain a stable body temperature with minimal oxygen need and without an increase in metabolic rate. The range of environmental temperature that allows this stability is called the Thermo-Neutral Zone. In healthy, unclothed, full-term newborns, an environmental temperature of 32 to 33.5 degrees Celsius, 89.6 to 92.3 Fahrenheit, provides a thermoneutral zone. When the infant is dressed, the thermoneutral range is 24 to 27 degrees Celsius, 75.2 to 80.6 degrees Fahrenheit. The thermoneutral zone for each infant varies according to the infant's gestational age, size, and postnatal age. Hyperthermia. Infants also respond poorly to hyperthermia. With an elevated temperature, the metabolic rate rises, causing an increased need for oxygen and glucose and possible metabolic acidosis. In addition, peripheral vasodilation leads to increased insensible fluid losses. Sweating may occur but is often delayed because sweat glands are immature. Newborns may be overheated by poorly regulated equipment designed to keep them warm. When radiant warmers, warming lights, or warmed incubators are used, the temperature mechanism must be set to vary the heat according to the infant's skin temperature and thus prevent heat that is too high or too low. Alarms to signal that the infant's temperature is too high or too low should be functioning properly. Hematologic adaptation. Factors that affect the blood. The blood volume of the term newborn is 80 to 100 milliliters per kilogram, but this varies according to the time of cord clamping, the gestational age of the infant, and the position of the infant when the cord is clamped. Preterm infants have a greater blood volume per kilogram than term infants. Blood samples drawn from the heel, where the circulation is sluggish, show higher hemoglobin, hematocrit, and erythrocyte values than samples taken from central areas. Venous blood samples are more accurate and are taken when precise measurement is essential. Blood values, erythrocytes, and hemoglobin. At birth, the infant has comparatively more erythrocytes, 4.8 million per microliter to 7.1 million per microliter, and higher hemoglobin, 15 to 24 grams per deciliter, levels in the adult. This difference is necessary because the partial pressure of oxygen in fetal blood is much lower than the normal adult level. Adequate oxygenation of the cells is possible because fetal hemoglobin carries 20 to 50% more oxygen than adult hemoglobin. Hematocrit. The hematocrit level in a normal newborn is 44% to 70% for the first month. A level above 65% from a central site indicates polycythemia, an abnormally high erythrocyte count. Polycythemia increases the risk for jaundice and injury to the brain and other organs as a result of blood stasis. Respiratory distress and hypoglycemia are more common in these infants. Leukocytes. The leukocyte white blood cell count at birth is 10,100 to 34,000. The average WBC count is 15,000 in term infants. The WBC count falls to 12,000 by 4 to 5 days after birth. In newborns, an elevated white blood cell count does not necessarily indicate infection. In fact, the WBC count may decrease in infections. Increased numbers of immature leukocytes are a sign of infection or sepsis in the neonate. The number of platelets, thrombocytes, also may decrease as a result of infections. Risk for clotting deficiency. Newborns are at risk for clotting deficiency during the first few days of life because they have low levels of vitamin K, which is necessary to activate several of the clotting factors, factors 2, prothrombin, 7, 9, and 10. Vitamin K is synthesized in the intestines, but food and normal intestinal flora are necessary for this process. At birth, the intestines are sterile and therefore unable to produce vitamin K. To decrease the risk for hemorrhagic disease of the newborn, Vitamin K is administered intramuscularly to most newborns in the United States during initial care. Drugs such as phenytoin, dilantin, phenobarbital, and anti-tuberculosis drugs taken by the mother during pregnancy interfere with clotting ability in the infant after birth. The platelet thrombocyte count ranges from 84,000 to 478,000 at birth. After the first week, platelet levels are the same as in the adult, 150,000 to 400,000. Although platelet counts in term newborns are near adult levels, platelet response to stimuli is decreased during the first few days of life. Gastrointestinal system. Newborns must begin to take in, digest, and absorb food after birth because the placenta is no longer performing these functions for them. Stomach. The newborn's stomach capacity is about 6 milliliters per kilogram at birth. Gastric emptying may be delayed at first. It is twice as rapid after ingestion of human milk than after formula, and slower if the infant has swallowed mucus. The gastrocolic reflex is stimulated when the stomach fills, causing increased intestinal peristalsis. Infants frequently pass a stool during or after a feeding. The cardiac sphincter between the esophagus and the stomach is relaxed, which explains the tendency to regurgitate feedings easily. Intestines. The intestines of the newborn are long in proportion to the infant's size and compared with those of the adult. The added length allows more surface area for absorption, but makes infants more prone to water loss should diarrhea develop. Air enters the gastrointestinal tract soon after birth, and bowel sounds may be heard beginning at 15 minutes after birth. The digestive tract is sterile at birth. Once the infant is exposed to the external environment and begins to take in fluids, bacteria enter the gastrointestinal tract. Normal intestinal flora are established within the first few days of life. Digestive enzymes. Maturation of the ability to digest and absorb occurs at different rates for various nutrients. Pancreatic amylase, needed to digest complex carbohydrates, is deficient for the first 4 to 6 months after birth. Amylase is also produced by the salivary glands, but in low amounts until about the 3rd month of life. Amylase is present in breast milk. The newborn is also deficient in pancreatic lipase, limiting fat absorption significantly. Lipase present in the mouth and stomach helps with some digestion of fat. Lipase is present in breast milk, which may make it more digestible for the newborn than formula. Protein and lactose, the major carbohydrate in the infant's milk diet, are both well digested. Stools. Meconium is the first stool excreted by the newborn. It consists of particles from amniotic fluids such as vernix, skin cells, and hair, along with cells shed from the intestinal tract, bile, and other intestinal secretions. Meconium is greenish-black with a thick, sticky, tar-like consistency. The first meconium stool is usually passed within 12 hours of life, and 99% of neonates pass meconium within 48 hours. If meconium is not passed within that time, obstruction is suspected. Meconium stools are followed by transitional stools, a combination of meconium and milk stools. They are greenish brown and of a looser consistency than meconium. Milk stools, characteristic of the type of feeding given to the infant, occur next. The stools of infants fed with breast milk are seedy and the color and consistency of mustard with a sweet sour odor. The breastfed infant generally has more frequent stools than the infant who is formula fed. A stool may be passed with each feeding. The normal breastfed newborn should have at least 4 or more stools daily after the 4th day of life. The formula-fed infant has pale yellow to light brown stools. They are firmer in consistency than those of the breastfed infant. The infant may excrete several stools daily, or only 1 or 2. The stools have the characteristic odor of feces. Hepatic System. The liver assumes many different functions after birth. Some of the most important include maintenance of blood glucose levels, conjugation of bilirubin, production of factors necessary for blood coagulation, storage of iron, and metabolism of drugs. Blood glucose maintenance. Throughout gestation, glucose is supplied to the fetus by the placenta. During the third trimester, glucose is stored as glycogen primarily in the fetal liver and skeletal muscles for use after birth. These stores are almost completely depleted within 12 hours after birth. They are used for energy during the stress of delivery and for breathing, heat production, movement against gravity, and activation of all functions that the neonate must assume at birth. Until newborns begin regular feedings and their intake is adequate to meet energy requirements, the glucose present in the body is used. As the blood glucose level falls, stored glycogen in the liver is converted to glucose for use. Although the brain can use alternative fuels such as ketones and fatty acids if necessary, glucose is the primary source of energy. Glucose concentration in the blood commonly falls to the lowest levels by 60 to 90 minutes after birth, but rises and stabilizes in 2 to 3 hours after birth. In the term infant, glucose levels should be 40 to 60 milligrams per deciliter on the first day and 50 to 90 milligrams per deciliter thereafter. There is no general consensus about the level of blood glucose that defines hypoglycemia, but a level below 40 to 45 milligrams per deciliter in the term infant is often used. Many newborns are at increased risk for hypoglycemia. In the preterm, late preterm, born between 34 weeks and 36 and 6-7 weeks of gestation, and small for gestational age infant, adequate stores of glycogen or even fat for metabolism may not have accumulated. Stores may be used up before birth in the post-term infant because of poor intrauterine nourishment from a deteriorating placenta. Infants who are large for gestational age and those with diabetic mothers may produce excessive insulin that consumes available glucose quickly. Infants exposed to stressors such as asphyxia or infection may exhaust their stores of glycogen. The cold, stressed infant may deplete glycogen to increase metabolism and raise body temperature. Conjugation of bilirubin. A major function of the liver is the conjugation of bilirubin. The newborn's liver may not be mature enough to prevent jaundice during the first week of life. Jaundice results from hyperbilirubinemia, excessive bilirubin in the blood. It occurs in 60% of term newborns and 80% of preterm infants. Source and effect of bilirubin. The principal source of bilirubin is the hemolysis of erythrocytes. This is normal occurrence after birth, when fewer erythrocytes are needed than during fetal life. The breakdown of red blood cells, RBCs, releases their components into the bloodstream to be reused by the body. Bilirubin remains as an unusable residue in the blood. This substance is toxic to the body and must be excreted. Bilirubin is released in an unconjugated form. Unconjugated bilirubin, also called indirect bilirubin, is soluble in fat, but not in water. Before excretion can occur, the liver must change it to a water-soluble form by a process called conjugation. The bilirubin is then known as conjugated or direct bilirubin. Conjugated bilirubin is not toxic to the body and can be excreted. Because unconjugated bilirubin is fat-soluble, it may be absorbed by the subcutaneous fat, causing the yellowish discoloration of the skin called jaundice. If enough unconjugated bilirubin accumulates in the blood, staining of the tissues in the brain may occur. This may cause acute bilirubin encephalopathy, a neurologic condition resulting from bilirubin toxicity. If this condition becomes chronic, it causes permanent neurologic injury known as kernicterus. The level of bilirubin necessary to cause injury to the central nervous system is unknown and may be different for various infants. Normal conjugation. When unconjugated bilirubin is released into the bloodstream, it attaches to binding sites on albumin in the plasma and is carried to the liver. If an adequate number of albumin binding sites are not available, bilirubin circulates as unbound or free unconjugated bilirubin. Bilirubin can be displaced from albumin by some medications. Free fatty acids, acidosis, and infection also decrease albumin binding of bilirubin. It is the free, unbound, unconjugated bilirubin that can move into the tissues and cross the blood-brain barrier. When the albumin-bound bilirubin reaches the liver, it is changed to the conjugated form of bilirubin by the enzyme uridine diphosphate glucuronyl transferase, UDPGT. Conjugated bilirubin is excreted into the bile and then into the duodenum. In the intestines, the normal flora act to reduce bilirubin to urobilinogen and stercobilin, which are excreted in the stools. Some urobilinogen is excreted by the kidneys. A small percentage of conjugated bilirubin may be deconjugated or converted back to the unconjugated state by the intestinal enzyme beta-glucuronidase. This enzyme is important in fetal life because only unconjugated bilirubin can be cleared by the placenta for conjugation by the mother's liver. In the newborn, deconjugated bilirubin in the intestines is reabsorbed into the portal circulation and carried back to the liver, where it again undergoes the conjugation process. The recirculation of bilirubin is called the enterohepatic circuit, and it creates additional work for the liver. Blood tests for bilirubin measure total serum bilirubin, TSB, and direct conjugated bilirubin in the serum. TSB is a combination of indirect, unconjugated, and direct bilirubin. Factors in increased bilirubin. A number of factors lead to the production of excessive amounts of bilirubin or interfere with the normal process of conjugation. These increase the incidence of jaundice during the first week of life. Excess production. Approximately 8 to 10 milligrams per kilogram of bilirubin is produced in newborns each day, a rate twice that in adults. The rate of production remains higher for 3 to 6 weeks. Newborns have more RBCs per kilogram than do adults. Red blood cell life. Fetal RBCs break down more quickly than adult erythrocytes. They last 80 to 100 days in term infants and 60 to 80 days in preterm infants, compared with RBCs in adults, which have a typical lifespan of 120 days. In addition, neonate erythrocytes are more fragile and susceptible to injury than those in the adult. Compared with adults, for their size, neonates have more RBCs breaking down faster and producing greater amounts of bilirubin to excrete. Albumin. Newborns have less albumin, decreased albumin binding capacity, and decreased albumin affinity for bilirubin than adults. Liver immaturity. The newborn's immature liver may not produce adequate amounts of UDPGT and other substances during the first few days of life. This limits the amount of bilirubin that can be conjugated. Blood incompatibility. Rh, ABO, or other incompatible blood between the mother and the infant may increase RBC breakdown. Gestation. Preterm and late preterm infants have immature conjugation abilities. Intestinal factors. At birth, the intestines of the newborn are sterile. Conjugated bilirubin cannot be reduced to urobilinogen or stercobilin for excretion without the action of intestinal flora. In addition, the newborn intestines have a large amount of enzyme beta-glucuronidase, which changes bilirubin back to the unconjugated state. Intestinal motility is decreased, allowing more time for the enzyme to act. These factors may result in high levels of unconjugated bilirubin, which is reabsorbed into the blood circulation. Delayed feeding. Feeding the newborn helps establish the normal intestinal flora and promotes passage of meconium, which is high in bilirubin. When feedings are delayed or taken poorly, normal flora are not established, and passage of meconium, which is high in bilirubin, is delayed. Delayed passage of stools allows more time for exposure to beta-glucuronidase, increasing the chance that conjugated bilirubin will be converted to the unconjugated state and absorbed into the blood. Trauma. Trauma during birth, such as bruising or a cephalohematoma, causes increased hemolysis of RBCs. As the RBCs in the traumatized areas break down, they add to the bilirubin load. Fatty acids. Fatty acids have a greater affinity than bilirubin for the binding sites on albumin and bind to albumin in place of bilirubin. Fatty acids are released when brown fat is used to increase heat during cold stress. During asphyxia, anaerobic metabolism also produces free fatty acids. Therefore, the level of unbound, unconjugated bilirubin is increased in these infants, and jaundice may develop. Family background. Infants who are Asian, American Indian, or Native Alaskan, or have a sibling who had jaundice, are more likely to be affected. Infants of diabetic mothers are also at increased risk for jaundice. Other factors. Some drugs, such as sulfazoxazole, given to the mother during pregnancy or to the infant, increase jaundice. Blood swallowed during birth, hypoglycemia, infection, and hemolytic anemias also increase jaundice. Hyperbilirubinemia. Physiologic jaundice. Physiologic jaundice, also called non-pathologic or developmental jaundice, is a transient hyperbilirubinemia and is considered normal. The jaundice is not present during the first 24 hours of life in term infants, but appears on the second or third day after birth. Jaundice becomes visible when the bilirubin level is greater than 5 milligrams per deciliter. The rate at which the bilirubin level in the blood rises and falls is important because it helps determine whether the rate for a particular infant is following the expected curve for age and birth weight. In physiologic jaundice, the bilirubin peaks between the second and fourth days of life and falls to normal levels by 5 to 7 days. The bilirubin level rises higher and falls more slowly in Asian infants. Non-physiologic jaundice. Jaundice that is physiologic or normal must be differentiated from non-physiologic or pathologic jaundice. One of the most important differences is the time at which jaundice appears. Pathologic jaundice may occur in the first 24 hours, when bilirubin rises higher or more rapidly than expected or stays elevated for longer than expected. Earlier treatment is needed to prevent severe hyperbilirubinemia. Non-physiologic jaundice is a result of abnormalities causing excessive destruction of RBCs or problems in bilirubin conjugation. These include incompatibilities between the mother's and infant's blood types, infection, and metabolic disorders. Non-physiologic jaundice is often treated with phototherapy. Charts are available that show the rise and fall of bilirubin and the degree of risk at various levels of TSB according to the age of the infant in hours. For example, a full-term infant with no complications who is 24 hours old is considered at low risk if the TSB is 5 milligrams per deciliter or less, and at high risk if the TSB is greater than 8 milligrams per deciliter. At 48 hours of age, that infant would be at low risk if the TSB were 8.5 milligrams per deciliter, but high risk if the TSB were that high before 48 hours. Infants who are preterm or late preterm or who have other risk factors may receive treatment for hyperbilirubinemia at lower TSB levels than full-term infants. Jaundice associated with breastfeeding. The breastfed infant has a higher risk for developing jaundice, which may begin early or late. Breastfeeding or early onset jaundice. Bilirubin levels greater than 12 milligrams per deciliter develop in 13% of breastfed infants by 1 week of age. The most common cause of jaundice in breastfed infants is insufficient intake. Jaundice begins within the first week of life, and serum bilirubin may reach dangerous levels if intake is not increased. Infants who are sleepy, have a poor suck, or nurse infrequently may not receive enough colostrum, the substance that precedes true breast milk, to benefit from its normal laxative effect in eliminating bilirubin-rich meconium. When meconium is not eliminated, the bilirubin may be deconjugated by beta-glucuronidase in the intestine, absorbed, and recirculated to the liver for conjugation again. Lack of adequate suckling depresses production of breast milk and increases the problem further. Helping the mother with breastfeeding to increase the infant's intake and stimulate milk production may be the most important treatment. Supplementing with formula interferes with the mother's milk production. However, if breastfeeding is inadequate and the infant is dehydrated or losing excessive weight, supplements of expressed breast milk or formula may be necessary. Glucose water will not reduce bilirubin levels and should be avoided. True breast milk jaundice. True breast milk jaundice, also called late onset breast milk jaundice, occurs after the first 3 to 5 days of life. It lasts 3 weeks to as long as 3 months for some infants. The TSB usually peaks at 5 to 10 milligrams per deciliter and falls gradually over several months. However, some infants reach levels of 20 to 30 milligrams per deciliter. The exact cause of true breast milk jaundice is unknown. Substances in the breast milk may increase absorption of bilirubin from the intestine or interfere with conjugation. Infants have no signs of illness. Treatment of breast milk jaundice includes close monitoring of TSB and at least 8 to 12 feedings each 24 hours. If bilirubin levels become too high, phototherapy is begun while the mother continues frequent breastfeeding. Interruption of breastfeeding is generally not recommended. However, if the TSB levels are dangerously high, the healthcare provider may order formula feeding be given for 1 to 3 days while the mother uses a breast pump to maintain milk supply. Temporarily switching to formula causes a rapid drop in bilirubin levels. If the level rises while breastfeeding is interrupted, jaundice from another cause should be investigated. The level may rise again when breastfeeding is resumed, but generally not high enough to interfere with further breastfeeding. Coagulation. Prothrombin and coagulation factors 2, 7, 9, and 10 are produced by the liver and activated by vitamin K, which is deficient in the newborn. Iron storage. Iron is stored in the fetal liver and spleen during the last weeks of pregnancy. Full-term infants who are breastfeeding usually do not need added iron until 6 months of age. At that time, they should begin iron-containing foods or iron supplements. All infants who are not breastfeeding should be given iron-fortified formula. The liver metabolizes drugs inefficiently in the newborn. This must be considered when drugs are given to the neonate. In addition, a breastfeeding mother should alert her primary caregiver before taking medications, because harmful amounts may be transferred to the infant via breast milk. Urinary system. Kidney development. By 34 to 36 weeks of gestation, the fetal kidneys have as many nephrons as adult kidneys. Blood flow to the kidneys increases after birth, and resistance in the renal vessels decreases. The improved perfusion results in a steady improvement in kidney function during the first few days of life. Newborn's kidney function is immature compared with that of the adult. The ability of the glomeruli to filter and the renal tubules to reabsorb is considerably less than in adults. The glomerular filtration rate doubles or triples during the first weeks of life, but does not reach adult levels until 1 to 2 years of age. Therefore, infants have a decreased ability to remove waste products from the blood. Small amounts of substances such as glucose and amino acids may escape into the urine of the neonate. They disappear within the first few days of life as kidney function improves. Uric acid crystals may give a reddish color to the urine that is sometimes mistaken for blood. Voiding occurs within 12 hours for 50% of newborns, 92% void within 24 hours, and 99% void within 48 hours of life. Failure to void within that time may be a result of hypovolemia from inadequate intake of fluids. Absence of kidneys or anomalies that interfere with excretion of urine are usually discovered before birth because they cause oligohydramnios, low amniotic fluid volume. This generally prompts investigation into the cause during pregnancy. Only 1 or 2 voidings may occur during the first 2 days of life, although a higher number is common. The infant voids 6 times a day by the 4th day. Fluid balance. Newborns have a lower tolerance for changes in total volume of body fluid than do older infants. This is because of the location of water within the newborn's body and the inability of the kidneys to adapt to large changes in fluid volume. In addition, the fluid turnover rate is greater than that in adults. To maintain fluid balance, full-term infants need 60 to 100 milliliters per kilogram, 27 to 45 milliliters per pound, daily during the first 3 to 5 days of life, and 150 to 175 milliliters per kilogram, 68 to 80 milliliters per pound, a day by 7 days of age. Water distribution. 78% of the newborn's body is composed of water. Intracellular water constitutes 34% of the body, and extracellular water makes up 44% of the body. interstitial water volume is 3 times greater than in adults. Although fluid within the cells is relatively stable, extracellular water is easily lost from the body. Because infants have more fluid for their size than adults, and because a larger proportion of it is located outside the cells, total body water is easily depleted. Conditions such as vomiting and diarrhea can quickly result in life-threatening dehydration. At birth, normal diuresis causes a 5 to 10% weight loss as excess extracellular water is lost. Insensible water loss. Water lost from the skin and respiratory tract contributes to insensible water loss. Insensible water losses are increased in the newborn because of the large surface area of the body and the rapid respiratory rate. Fluid losses increase greatly when infants are placed under radiant warmers or phototherapy lights, which accelerate evaporation from the skin. An elevated respiratory rate or low humidity in the air surrounding the infant raises insensible water losses even further. Urine dilution and concentration. The ability of a newborn's kidneys to dilute urine is similar to that of adults, but they have only half the adult's ability to concentrate urine. However, a newborn's kidneys cannot handle large increases in fluids, which result in fluid overload. This is most likely to happen if infants receive too much intravenous fluid. Normal urine output is 2 to 5 milliliters per kilogram per hour, and urine-specific gravity is 1.002 to 1.01. When abnormal conditions such as diarrhea cause excessive loss of fluid, the newborn's limited ability to conserve water may result in dehydration more quickly than in the older infant or child. Acid-base and electrolyte balance. The maintenance of acid-base and electrolyte balance is a primary function of the kidneys and may be precarious in neonates. Newborns tend to lose bicarbonate at lower levels than adults, increasing their risk for metabolic acidosis. The excretion of solutes also is less efficient in newborns. Although newborns conserve needed sodium well, they are limited in excretion of sodium. This is especially a problem if they receive excessive amounts. Immune system. The neonate is less effective in fighting infection than the older infant or child. Leukocytes are delayed in moving to the site of invasion and are inefficient in destroying the invader. The infant's decreased ability to localize infection leads to a tendency towards generalized sepsis. Fever and leukocytosis, which occur during infection of the older child, are often not present in the newborn with infection. This lack of response occurs because the hypothalamus and inflammatory responses are immature. Nonspecific signs such as changes in activity, color, tone, or feeding may be the only signs of sepsis. Because of their immature immune system, infants are susceptible to some pathogens that do not usually affect older children. Full-term newborns receive antibodies from their mothers during the last trimester of pregnancy. The mother continues to provide passive antibodies to the infant in her milk if she chooses to breastfeed. Immunoglobulins, serum globulins with antibody activity, help protect the newborn from infection. The major immunoglobulins are IgG, IgM, and IgA, each of which perform a different function. At birth, the infant's total immunoglobulin levels range from 55% to 80% of the adult levels. Immunoglobulin G. Only immunoglobulin G, IgG, crosses the placenta, with passage beginning in the first trimester. Preterm infants have less IgG because transfer is greatest during the third trimester. IgG provides the fetus with passive temporary immunity to bacteria, bacterial toxins, and viruses to which the mother has developed immunity. The full-term infant has IgG levels that are as high as or higher than those of the mother. Although the fetus makes some IgG, significant production of IgG is delayed until after 6 months of age. The infant gradually produces larger quantities of the immunoglobulin to replace IgG from the mother, which is being catabolized. The passive immunity gradually disappears, reaching the lowest level at 2 to 4 months of age. Immunoglobulin M. IgM is the first immunoglobulin produced by the body when the newborn is challenged. This immunoglobulin helps protect against gram-negative bacteria, Rapid production of IgM begins a few days after birth as a result of exposure to environmental antigens. IgM cannot cross the placenta because the molecules are too large. If IgM is found in cord blood, exposure to infection in utero has occurred. IgA. IgA also does not cross the placenta and must be produced by the infant. IgA is important in protection of the gastrointestinal and respiratory systems, and newborns are particularly susceptible to infections of those systems. Secretory IgA is present in colostrum and breast milk. Therefore, breastfed infants may receive protection that formula-fed infants do not. Psychosocial adaptation. Periods of reactivity. In the early hours after birth, the infant goes through changes called periods of reactivity. The two periods of reactivity are separated by a period of sleep or decreased activity. First period of reactivity begins at birth and lasts for 30 minutes. Infants are active at this time and appear wide awake, alert, and interested in their surroundings. Parents enjoy watching the infant gaze directly at them when held in the en face, face-to-face position. Infants move their arms and legs energetically, root, and appear hungry. If asked to nurse, many infants latch on to the nipple and suck well. The temperature may be decreased during this period. Respirations may be as high as 80 breaths per minute. The heart rate may be elevated to 180 beats per minute. Crackles, grunting, retractions, and nasal flaring may be present. The pulse and respiratory rates gradually slow, and the infant becomes sleepy. Period of sleep or decreased activity. After the first period of reactivity, infants become quieter or fall into a deep sleep. During this time, the pulse and respirations drop into the normal range. Bowel sounds are audible and meconium may be passed. Second period of reactivity. The second period of reactivity lasts 4 to 6 hours. Infants have alert periods, and parents may enjoy the opportunity to get to know their infant at this time. Infants become interested in feeding and may pass meconium. Baby tachycardia and rapid respirations. Mucus secretions increase, and infants may gag or regurgitate. Behavioral states. 6 gradations in the behavioral state of the infant have been identified, ranging from quiet sleep to crying. The amount of time infants spend in the different sleep-wake state varies and is key to their individuality. Deep or quiet sleep state. During the quiet sleep state, the infant is in a deep sleep with closed eyes and no eye movements. Respirations are quiet, regular, and slower than in the other states. Although startles occur at intervals, the infant's body is quiet. The infant is very difficult to arouse and will not feed. Light or active sleep state. The active sleep state is a lighter sleep in which the infant's eyes are closed. They move their extremities, stretch, change facial expressions, make sucking movements, and may fuss briefly. During this period, respirations tend to be more rapid and irregular, and rapid eye movements occur. Infants are more likely to startle from noise or disturbances and may return to sleep or move to an awake state. Drowsy state. The drowsy state is a transitional period between sleep and waking, similar to that experienced by adults as they awaken. The eyes may remain closed, or if open, appear glazed and unfocused. Infants startle and move their extremities slowly. They may go back to sleep, or with gentle stimulation, gradually awaken. Quiet alert state. The quiet alert state, also called alert inactivity, should be pointed out to parents because it is an excellent time to increase bonding. Infants focus on objects or people, respond to the parents with intense gazing, and seem bright and interested in their surroundings. They respond to stimuli and interaction with others. Body movements are minimal as infants seem to concentrate on the environment. Active alert state. In the active alert state, infants seem restless, have increased motor movements, and may be fussy. Infants have faster and more irregular respirations, may hiccup or regurgitate, and seem more aware of feelings of discomfort from hunger or cold. Although their eyes may be open, infants seem less focused on visual stimuli than during the quiet alert state. Crying state. The crying state may quickly follow the active alert state if no intervention occurs to comfort the infant. The cries are continuous and lusty. Active body movement occurs, and the infant does not respond positively to stimulation. Respirations are irregular and rapid. It may take a period of comforting to move the infant to a state in which feeding or other activities can be accomplished.